So good morning, everyone. It's my genuine pleasure to welcome all of you here this morning, those of you who are here in person, and there are quite a few filling the room, and those of you who have joined us online. I'm Carol Swallow, the chair of the department, and this is a very special version of our annual Gallie Day, our big academic day in the Department of Surgery. This is our 50th anniversary, and we have a lot of special treats planned for you throughout the day and this evening. I think you're going to find that it's a great day of science, discussion about surgery, and the role of surgeons in society. So to begin, I'd like to acknowledge on behalf of everyone that the land on which the University of Toronto sits and the land upon which we are currently gathering was for thousands of years the traditional homeland of many Indigenous peoples, including the Anishinaabe, the Haudenosaunee, the Huron-Wendat, and more recently the Mississaugas of the Credit. And today it is still home to many different Indigenous peoples, and we strive to work with them to respect this land, to treat it better, and to uphold the 94 calls to action of the Truth and Reconciliation Commission of Canada, recognizing that the majority of them remain unfulfilled. The day is named after Dr. William E. Gallie, who is a former chair of the Department of Surgery here at the University of Toronto. He hailed from Barrie, Ontario, that great metropolis to the north. You might be familiar with it. It's on Lake Simcoe. And he did his medical school and most of his surgical training in Toronto, had some experience during the war and came back to become the chair, later the dean of the medical school, and subsequently the president of the American College of Surgeons. Dr. Gallie was known for his focus on innovation and his interest in using evidence and experimenting in order to generate evidence to guide our practice. But perhaps most saliently, Dr. Gallie remains a hero for having created the Gallie course. So those of you who are training in surgery at the University of Toronto are members, whether you know it or not, of the Gallie course. This was innovative in itself at the time because it recognized that surgeons should be trained methodically, and in a planned manner with a curriculum, rather than just a sort of itinerant apprenticeship model. So all of us have benefited from that throughout the years, and it's been a model for training in Canada, North America, and the world. So today we're celebrating Dr. Gallie's legacy by listening to this science that has been generated by many of the trainees who are here in the room and their faculty mentors. I think we can all be very proud of the work of the research committee and of its vice chair of research, Michael Failings. Michael is going to introduce us to the program for the day, which is absolutely fantastic, and we welcome our guest lecturer, the Gordon Murray lecturer, Dr. John Mara from Harvard University. I know from speaking with you last night that we're going to have a great talk later this morning. So please participate, listen, learn, enjoy being together again, and thank you for being here. Michael.
Thank you, Carol. It was beautiful artwork, by the way, that you showed there. That was gorgeous. So welcome to the 50th Gallie Day. What a remarkable tradition it has been. And we're going to really, I think, this year celebrate what I think has emerged as an extremely important theme, and perhaps, given, the challenges that we're also seeing, internationally, this is even more relevant now. And this relates to the impact of global surgery on human health. And as Professor Swallow has indicated it's really our honor to welcome as the 2024 Gordon Murray Lecturer, Professor John Miara from Harvard, and I'll more formally introduce John a little later this morning at the symposium. And I have a number of people to acknowledge, and we'll kind of go through a few slides. And just to give you a little bit of a snapshot of the accomplishments in research in the Department of Surgery. So firstly, I just want to acknowledge the research committee, and we have a very vibrant and active research committee. They've been very actively involved with our surgeon scientist training program, with a lot of the strategic initiatives that we have, as well as with the organization and the practicalities of Gallie Day. So I won't read everyone's name, but I'll just mention kind of a few people. I want to firstly acknowledge Renata Musa, who is kind of my right-hand person in research in the Department of Surgery, and along with Sylvia and the administrative team in the department has really put together today. So she deserves a lot of credit. I also want to recognize Professor Andras Kapush, who's the Associate Vice Chair, and Andras is a full-time faculty scientist, and this is also to serve as an acknowledgement that in addition to clinicians, we have full-time basic and clinical scientists in our department who serve a very valuable role. And then we have an integral relationship with training, and I wanted to just recognize Lorene and Malik as our two resident representatives on the research committee as well. So this is just a list of names of the various trainees in our surgeon scientist training program, and this kind of gives you kind of a sense of the fluctuations over the years. But generally, we are somewhere around 40 trainees per year, plus minus, and just showing the mixture between kind of new entries and continuing entries. And this is just the list of our program currently. So we have 34 surgical trainees currently undertaking master's degrees or PhD degrees, and these are all thesis-based degrees. So again, for today, I wanted to again acknowledge Renata, but I also wanted to acknowledge Anna Dare and Andrea McCart, who've had a big role in terms of the organization and the logistics, and Anna is our chair in global surgery and has been integral in terms of the organization of the symposium that we will have later today to complement Professor Miara's talk. So this will be on global surgery. And we've had a pretty stellar year in terms of grant funding, well over $100 million in peer-reviewed grant support. And publications are very high impact and generally hovering between 1,400 and 1,500 per year. And importantly, many of these are very high impact publications as well. And the University of Toronto Department of Surgery fares very well in international ratings in this regard. So I also want to acknowledge and thank all the people that have kind of contributed to the organization of the oral presentations, our poster presentations, the various judges. I won't read out everyone's name, but we're very grateful and to these people. And we in addition to the oral presentations, which will feature both trainees in the surgeon scientist training program, as well as students who are in the labs and research programs of faculty in the department. We also have some amazing poster presentations, and we had actually a record year in terms of the number of poster presentations. We actually had to go to 3 e-poster presentations, and as in the past, these will be kind of live presentations, but with an electronic format. So please attend those presentations. The science is amazing. And feedback is really a key, and so we'd love to hear your feedback. We'd love to get ideas in terms of future themes, areas that you'd like to hear about, and I think this is very helpful for us. We would welcome this. So on that note, I'm going to hand over to my dear colleague, Professor Moji Hodai, who will chair the first session.
Our next presentation is by Jack Hickmott from Cindy Moorhead's lab. Jack earned his PhD from UBC in 2018 and studied gene therapy approaches to rare ocular disorders. And following that, he did a postdoctoral fellowship at Imperial College in London, working on pulmonary gene therapy for alpha-1 antitrypsin, and developed new technologies in that area. He's now back in Canada working in Cindy Moorhead's lab, exploring novel gene therapy approaches to reprogram astrocytes. The title for his talk is Turning Astrocytes into Neurons, Developing Gene Therapy Approaches to Repair the Stroke-Injured Brain. Jack, thank you very much.
Thank you very much. Thank you, everybody, for inviting me here today. It's such a delight to talk to you about something that's going to change gears a little bit. We're going to go into the brain, and we're going to go into molecular data and talk about gene therapy. And it's such a fantastic time to be working in gene therapy because at the moment, it's really enjoying a lot of successes that are changing the way that we can treat some previously incurable diseases and giving us kind of a new pillar to go into medicine. And so the kind of gene therapy that I'm sure a lot of people are really familiar with are kind of the gene replacement strategies. So you inherit non-functioning versions of a gene from your parents. We try and go back in and put a functioning version of that gene into your body to kind of really fix the problem at its core. The other kind of gene therapy is giving cells new function. And this is more where I'm going to be dwelling on today, where you take a cell like a T cell, for instance, and then you give it the receptors that it needs to actually be able to go and find a cancer cell, unlike it would normally do, and that it can go and hunt down cancers and kill them. So this is kind of giving the body the ability to do things that it wasn't able to do before. But how do we do that? Well, the underlying premise really of gene therapy is putting new genes into the cell. And this is accomplished a lot with vectors such as this viral vector, our adeno-associated virus, where it's a really simple, safe, clinically relevant vector because it doesn't really cause any known pathology. It can target a lot of different cell types. And it's really just made of two components, a protein-based capsid or coat, and inside that is a DNA genome. And in that genome, we basically scoop out almost all of the viral components, and we replace that with two pieces. One, a promoter, which is kind of the on switch for our gene therapy. So if you put, say, a liver-based promoter in, it's going to turn on in liver cells, but not in CNS cells. And the opposite, if you put in, say, a neuron promoter, it's not going to turn on in astrocytes or something like that. So we package that all together, put it in the AAV, inject it into a person, and that is how we can go ahead and, say, cure SMA with Zolgensma because it's replacing missing genes that the patient needs. And so we thought, well, a lot of these gene therapies are targeting fairly rare disorders, but there's a broad application and kind of a need for things, especially in the CNS, where the financial and social burdens on society are quite high. And one of the things that a lot of CNS disorders have in common is that the phenotypes are driven by a loss of neurons. And so there's this technology called cellular reprogramming, or changing one cell type into the other, that we thought would be really applicable here. And so if you're turning one cell type in the other, the first question you need to ask yourself is, what cell am I changing and what am I changing it into? I think with CNS disorders, it's pretty clear what you want to change things into. That's going to be neurons, because that's what's lost in a lot of these disorders, and it's kind of correlated with the phenotypes that you see in the patients. But then what's your target cell? We've been looking at glia, and particularly astrocytes, both because, unlike neurons, they actually have the capacity to proliferate. And so if we take away some of the astrocytes and turn them into neurons, they have the opportunity to replace themselves. But also because a lot of them actually have a role in the pathology of a lot of these CNS disorders. And so by changing those astrocytes, we may be able to kind of get a double whammy. We're taking away something that's causing some harm and turning it into something that's doing some good. Well, how do you go about doing that? What we're using is the aforementioned AAVs, and then we're patching it together with a promoter, the short human GFAP promoter, that is specific for astrocytes. And not only is it specific for astrocytes, it's really interesting. It seems that in a lot of CNS disorders, astrocytes will upregulate GFAP when they're in distress, and in this kind of astrocytes that might be causing some pathology. And so we can kind of target that population of astrocytes specifically. And then we use that astrocyte-specific promoter to drive the expression of our neurogenic transcription factors. So these are a lot of the basic loop helix loop transcription factors found in development that help push cell types towards neurons. And there's a lot of evidence to show that this can be done in adult cells as well. And so this technology is not based on a poor platform. Actually, there's a strong foundation for it. Going back as early as 2010, we've been able to show in a dish that you can take some fibroblasts, put in a combination of transcription factors, and those transcription factors will then turn those fibroblasts into new neurons. As you can see, over multiple days, they kind of get that longer, more neuronal phenotype. In the Moorehead lab, we've also shown that we can put together an AAV that if we inject it into a mouse brain, will turn astrocytes into neurons. That's what you're seeing on the right here, where if we just put in a control, so something that's just going to label cells, we don't really have a lot of red and green overlapping. So the cells that we're transducing are not looking like our neurons. However, if you put in one of our transcription factors, that actually starts changing the cell, and we start getting these astrocytes turning into neurons, and that's where you get the yellow cells on the right. And if we just quantify that, you can see that we get a significant increase in the number of new neurons that are appearing in these mouse brains. And so that's really exciting and a great platform to kind of build research and start thinking about translating to the clinic. But at the same time, it almost opens up more questions than it answers. And so there's lots of things that we're actively trying to discover in this space right now. For instance, what is the underlying mechanism? Can we actually watch an astrocyte turn into a neuron, and what exactly is happening at the molecular level there? Cell targeting. Glia cells and even just astrocytes themselves are incredibly heterogeneous. And so which one are the right ones to be specifically targeting? Cargo. There's lots of different neurogenic transcription factors. Which ones are the best ones for each indication? Delivery vehicles. I've talked a lot about AAV, but there's tons of different ways of getting things into cells, including lentiviruses and non-viral vectors. So all of those need to be considered as well. And then there's gene delivery. So are we going to be opening up a patient's skull and injecting virus directly into it? Or are we trying to do something clever, like putting it into the bloodstream and finding ways of making the blood-brain barrier more permeable to viruses so that they can actually get in there? And so for the rest of my talk, I'm going to be really focusing on two things. The cell targeting and a bit around the gene delivery itself, because these are two of the major challenges that we've been trying to tackle in the last little while. So we were looking primarily in the motor cortex before, and we kind of realized that there's going to be a need to be able to use these neural repair mechanisms in more places than just the motor cortex in the brain. So we started by moving just a little bit over into the medial prefrontal cortex and just doing some basic experiments. We're not reprogramming anything, but we're just seeing how our vectors respond there. And very much as expected, inside the motor cortex, when we put in our vectors, the majority of the cells that they're active in are astrocytes. However, when we move just a little bit over into the medial prefrontal cortex, this whole story started to change quite a bit, and the astrocyte targeting went way down, and the number of neurons that our vectors were active in went way up. And this created kind of a conundrum for us, because if we're going to be changing one cell type into the other, we want to be quite specific in what we're actually going to be turning, or what we're going to be changing. And so we wanted to explore some of the reasons why this might be. And our first thought might be that it had something to do with the vector. So for instance, are we putting too much of the virus in? And maybe that's just overloading the cells and it's working inappropriately in different cell types. And so we just did this dose response where we just put increasing amounts of AAV inside both of these two brain regions. So the blue is the motor cortex and the red is the medial prefrontal cortex. And if we went up by, say, 100-fold amount of virus that we're putting into these brains, the proportion still stayed the same. So it didn't seem to be making a big difference there. The other thing we thought that is maybe in the medial prefrontal cortex, the virus just likes getting into neurons better. So we took away our specific astrocyte targeting, put in a promoter that will express in any cell type that we look at, and what we found is in the medial prefrontal cortex and the motor cortex, they're expressing in the same numbers of cells, and more importantly, they're expressing in the same proportions of astrocytes and neurons. So it seems like the virus itself is doing a really good job, and there's something else at play. And this got us to look at some of our core tools, including, say, that GFAP promoter that we thought was a really, really good target to use, and maybe that's having some kind of problem with targeting neurons in different parts of the brain. And so we went into the literature and we found a different promoter that also targets astrocytes. This is called the S100 beta promoter. And the first thing we wanted to do when we were playing with it is just make sure that it's roughly equivalent to the short GFAP promoter, because if it's getting into or active in, say, 10% of the cells that the other one is, that's probably not going to make a very good therapeutic. And so very quickly, we saw equivalency in the number of cells that it was transducing in. If we looked specifically at the astrocytes, we saw that they were getting into very similar numbers of astrocytes. And then finally, when we looked at neurons, we saw that in the motor cortex, it was expressing or misexpressing in roughly similar numbers of neurons in the motor cortex. So then we wanted to challenge the system a little bit more, say put it into a context where we might be doing some reprogramming, like stroke. So we used an endothelin-1 model of stroke where we just basically inject this small molecule into the motor cortex. This causes the blood vessels to contract and leads to a stroke. Then we put our vectors in following that. And that's where things got really interesting, because you can see here, using the short GFAP promoter, we're actually starting to get expression in neurons where we weren't really seeing it before. And if we quantify that, what really happened was our new promoter was doing a better job of targeting the astrocytes in these cells, and at the same time, it was doing a better job of not getting into the neurons in these cells. And so this seems like a really strong tool for us to be moving forward with as we're targeting astrocytes to turn them into new neurons. And so what I want to kind of leave you guys here with today is that there's a lot of exciting potential for using these therapies to replace the neurons that are lost during neurodegenerative diseases and other disorders of the CNS, but we still have a lot of questions to ask as we start trying to translate this towards the clinic. So I want to thank, first of all, the research committee today, my lab mates and all those who contributed to these studies, our collaborators, and our funders. I'd be happy to take your questions. Thank you so much.
Thank you very much, Jack. Dr. Gellerzade is a discussant for this paper.
Thank you, Margie. That was really great. Amazing work. I have a few questions, probably more than time permits. So in the world of the work I do, adenoviruses, modified viruses hold a lot of promise with respect to being able to tackle a tumor and prevent its progression. And really, it's as a consequence of the immune inflammatory reaction that they induce. So in the disease processes that you showed, in fact, that reaction is not favorable. It would be less than desirable reaction that you'd want to
Yeah,
induce.
kind of
So,
taking an inflammatory brain and inducing more inflammation kind of thing.
so, you know, it will obviously contribute to scar formation, to what we don't want in neurodegeneration, spine, stroke. So some thoughts around that as to how you would mitigate that once you have delivery with the adenovirus or any other viral vector. And then the second is your animal models. As you know, GFAP has very different forms of the promoter, and it's quite leaky. So that although in mice you would see good results potentially, how would that translate to human? Because also S100 is not specific, and it could in fact influence your neuronal reaction to the delivery. So maybe a little bit of discussion around that as to where then to point the next steps to be able to mitigate some of these concerns. But really amazing work. Thank you.
Absolutely. Thank you so much for the questions. So starting at the beginning with the neuroinflammatory response, I mean, part of what we're excited about is using promoters like GFAP and S100 beta because they are also involved in the neuroinflammatory response. And so we're kind of trying to target those cells that are going to be becoming more reactive. And trying to actually take them away by reprogramming them away from being neuroreactive and actually contributing more to the neuronal circuitry. But in addition to that, we're also exploring some drugs that we're going to be hopefully co-administering with these AAVs that will be dampening some of the inflammatory responses too. And so that's kind of in very early phases and working with some of the industry leaders in Canada around that. So we're hoping to kind of tackle that issue in two different ways. Now going on to the promoter selection, I mean, you bring up a really excellent point, and focusing on GFAP promoter in mice might not translate very well to GFAP promoter in human because a lot of these things never been used in humans before. First of all, we're studying that not just in our mouse models, but taking that to human cerebral organoids to see how it's translating to some of those cells. Again, not a perfect model of human, but better. And then we also have some collaborators who are working on human Mueller glia and astrocyte cell lines to see how these promoters behave inside those cells as well. So similarly, we'll be interested in seeing what we can do with the S100 beta to see if we can get better specificity for the GFAP promoter there, because you're right, like it could be leaky. This promoter in particular is quite a long one and a fairly novel one, so it hasn't been very well studied in a lot of different models yet. And so I think going broad with it and seeing how it behaves in a lot of different models gives us our best chance to actually making it have success. Then similar to the GFAP promoter as well, it's also based off of human DNA sequences, so we're trying to make sure that we're getting as close to human, putting human inside human when we're doing it for the best chance of translational success. Thank you.
Thank you very much. I'll try do my best to keep us to time. Okay, we move to our next presentation, Dr. Kumi Masaki. Dr. Masaki is a postdoctoral fellow in Dr. Shaf Keshavji's lab in the thoracic research laboratories, and the focus of her research, genetic engineering of donor organs to enhance outcomes in lung transplantation. The title of her talk is Genetic Editing to Immunologically Modify Donor Lungs for Transplantation Using CRISPR-Cas technologies. Please, Dr. Masaki, go ahead.
Thank you for the introduction. It is a great honor to be here, and I would like to thank the Gallie Day Research and Organizing Committee for this opportunity. I will present our study of harnessing genome editing to immunologically modify donor lungs for transplantation using CRISPR-Cas technologies. Lifelong systemic immunosuppression in recipients to prevent graft rejection is one of the major impediments to post-transplant outcomes in lung transplantation. Immunosuppression increases the risk of severe complications such as infection and malignancy and drug adverse effects that leads to morbidity and mortality. We envisioned overcoming this challenge by engineering donor lungs with long-lasting immunomodulatory capacity. One promising strategy is to treat the whole donor organ outside the body prior to implantation. This therapeutic vision could become a practical reality in clinic with the advent of ex vivo lung perfusion platform. We seek to genetically modify donor lungs to induce sustained graft immunomodulation in recipients. Genome editing represents a powerful approach to induce persistent effects by changing the host genomic DNA. We hypothesize that one-time treatment of genetic modification of donor organ could improve post-transplant graft injury and potentially reduce the need for systemic immunosuppression in recipients. Importantly, this could be implemented into clinical practice with ease as off-the-shelf treatment. To realize our therapeutic vision, we first explored genome editing approach and developed optimized delivery vector for whole organ modification. We then evaluated genome editing intervention using ex vivo perfused human donor lungs and in vivo rat model for future clinical translation. To achieve genome editing in the donor organ, we applied CRISPR-Cas technologies. CRISPR system employs Cas nuclease and a sequence-specific small RNA, which is called guide RNA. When these two components are delivered to cells, the guide RNA recruits the Cas enzyme to the target genomic locus that leads to permanent editing of the host genomic DNA at specific site. In short, simple delivery of Cas enzyme and guide RNA could accomplish editing in the donor lung. We selected an immunomodulatory gene, IL-10, as one of the candidate targets for graft immunomodulation. Exploring editing approach for organ modification, we found that installing mutation into the regulatory element significantly enhanced IL-10 expression in human cells by a de-depression mechanism. This approach also upregulated endogenous IL-10 gene in rat and porcine cell lines that are two animal species used in the translational path. In applying to donor organ modification, the lead time of the genome editing has become a challenge. Genome editing often takes a couple of days, which exceeds the duration of pre-implantation ex vivo lung perfusion. To achieve early graft immunomodulation, we constructed a unique vector where we additionally packaged IL-10 cDNA together with genome editing enzymes. This vector is designed to induce early IL-10 expression from the cDNA and sustained IL-10 upregulation by CRISPR-Cas genome editing. Evaluation of this vector in cultured cells demonstrated both early and long-lasting IL-10 expression as designed. Using this vector, we aim to address both the early innate immune response of ischemia reperfusion injury and the late adaptive immune response of graft rejection by one-time organ treatment before implantation. In clinical application, human relevant preclinical assessment remains a challenge for genome targeting interventions. Therapeutic development often starts with a human genome editing design. However, there is a significant gap before clinical trials due to a lack of good models to recapitulate complex organ systems in the body. Therefore, more sophisticated modalities using human materials are highly demanded. We aim to overcome this barrier by harnessing the expertise in ex vivo organ perfusion. We hypothesize that testing genome targeting therapeutics in ex vivo perfused human organs could provide important human relevant information. To prove our concept, we perfused human donor lungs using ex vivo lung perfusion and delivered adenoviral vectors carrying IL-10 cDNA and editing enzymes through the airway. To follow up the treated lung after perfusion, we generated thin tissue slices using precision-cut lung slice technology at the end of 12 hours of post-intervention perfusion. This design enables observation of the tissues from the treated lung to 2 weeks, which is well beyond the duration of ex vivo lung perfusion. We first validated the viability of lung tissue slices generated after ex vivo perfusion in a pilot case. Both the live cell staining and functional metabolic assay demonstrated retained viability of the cultured slices. We also detected Cas9 expression in the slices from the treated lung. Building on this, we perfused human lungs from 2 donors and delivered vectors during ex vivo perfusion. To make the most of the human donor lungs, the whole lung was split and each lung was perfused individually using separate circuits. The treated lungs were stably perfused for 12 hours after the transairway delivery of vectors. We observed an increase in IL-10 protein in the bronchial wash and lung tissue during the normothermic perfusion period. The tissue slices from the treated lung exhibited enhanced IL-10 production on day 7. We also found that higher IL-10 production was associated with lower levels of TNF-alpha, indicating immunomodulatory potential of the IL-10. Importantly, we demonstrated significant editing in the tissue slices from the treated human lung with high IL-10 production that was sustained for at least 14 days. 2 major limitations of assessment using ex vivo perfused human organs are the absence of the body system and the limited follow-up period. To overcome these challenges, we conducted in vivo study using a rat model. We delivered IL-10 cDNA and genome editing enzymes to the rat lung in vivo using adenoviral vectors. Treatment induced early increase in the IL-10 protein levels in the lung tissue. Importantly, the edited cells in the lung persisted for at least 28 days. The treated lungs lacked signs of edema and inflammation, supporting that the treatment was tolerated. In conclusion, we developed a novel genome editing approach and optimized vectors for whole organ modification. We evaluated this genome editing intervention for the first time in human donor lungs ex vivo, simulating organ modification prior to implantation. Our findings could lay the path towards a new frontier of organ immune engineering and clinical translation to overcome challenges in patient care. This study has been conducted with the help from exceptional team and collaborators. I would like to thank Dr. Keshavji for all the support to dive into the organ engineering in the new era of genetic medicine. Thank you very much.
Thank you, Dr. Masaki. Discussant for this paper is Dr. Andrew Sage.
Thanks, Kumi. That's a wonderful presentation, and it's really exciting work. So I have kind of a couple of questions as it relates to where we can go with this. So when we think about gene modifying the whole organ at the CRISPR level, interleukin-10 has been shown to be a very important biomarker for lung transplant. As we think towards maybe wanting to modify 5, 10 genes simultaneously, what would be the strategy to do that? Would it be successive rounds of EVLP, or could it be done in a multiplex manner? And are there any limitations to the multiplexing capabilities?
Yeah, CRISPR system has strengths in multiplex gene modulation, so we can deliver different guide RNA targeting the different genes simultaneously using single vector. So the treatment would be the same, and we can change the vector to target the multiple genes.
And sort of then the follow-up question is do you envision a treat-all approach to donor lungs, or would it be a tailored approach to each lung? And so how would you kind of envision that?
So potentially, if we could generate one very excellent vector that targets multiple genes, generally benefits the patient outcome, that would be great. But in some cases, there could be particular needs, individual needs. So we could prepare the tailored vector for each cases, and based on the assessment, molecular diagnostics during the ex vivo lung perfusion, we could select the most optimal vectors for that lung.
Can I ask one more? Yeah. One more final question. So in your experiments, as you move from ex vivo to PCLS, one can imagine the temperature is fairly consistent. In the clinical side, right, we would probably see this sort of ebb and flow as we have a 37-degree EVLP and then a cool down. So do you imagine the efficacy to remain the same at each temperature, or what would be the thoughts there?
So the previous animal studies and the ongoing studies, we saw that delivered vector viral DNA is stable during the temperature change, but what changes is gene expression. So we could retain the same level of the transgene expression, transgene product during the cold preservation, and when we warm up the lung, the transgene expression continue to increase from the where it stopped. Yeah.
Excellent. Thank you very much.
Thank you very much, Dr. Masaki. Okay, moving right along to our next presentation, and that is Dr. Alex Landry. Dr. Landry is a surgeon scientist training program neurosurgery resident who's currently completing his PhD, which focuses on integrating computational models with genomics to understand tumor heterogeneity, develop clinically useful predictive models, and identify novel therapeutic vulnerabilities. The title of his talk is Integration of CSF methylome and proteome can obviate the need for surgical biopsy in CNS lymphoma. Alex.
Okay, thank you very much. It's a pleasure to be here. I'm going to talk about some of the work we've done on liquid biopsy and brain cancer. So here I show you 3 different MRI scans from 3 different patients. To the untrained eye and even the trained eye, you can see that these brain tumors are relatively indistinguishable from one another. So it's a little bit difficult early on to counsel the patient on what the next steps are. The trouble is that for each of these 3 patients, the next step is a surgical intervention, but that surgical intervention depends on the diagnosis. In these cases, these patients happen to have 3 very different diagnoses. So the first example is a brain metastasis, so a patient that has tumor that's spread from elsewhere in the body. The second is a glioblastoma, or GBM, which is one of the more common types of aggressive primary brain cancers. And the third is a lymphoma that grows and originates in the CSF, or the CNS, excuse me. The trouble is that the goal of surgery for each of these patients is vastly different. So a patient with a brain metastasis or a glioblastoma, we know that they derive a significant outcome benefit by doing a maximal safe resection. So those patients are treated best by going to the operating room. We do a craniotomy, a big surgery. We take out as much of the cancer cells as we can, and they go on often to chemotherapy and radiation. The role of surgery in lymphoma, on the other hand, is limited purely to surgical biopsy. So that same outcome benefit is not borne out by aggressive surgery, and they're better treated with a biopsy. So you can see we basically are faced with this chicken and egg phenomenon where we have a patient and we need the diagnosis to know what surgery to do, but in order to get the diagnosis, we need to do one of these surgeries. So to kind of pictorially represent this, this is essentially the pathway of a lot of centers when we face these new intraaxial brain tumors, so tumors that grow from within the brain tissue itself. We basically make a guess based on the radiologic features and the clinical features, and if we think it's something that would be benefited from an aggressive surgery, we go straight to that option. So we take the patient to surgery, we do a big craniotomy, and we take out as much of this tumor as we can do. If we think it's a lymphoma, the pathway is a little bit different because we know we shouldn't be doing aggressive surgery. So we do a needle biopsy. Of course, our needle is a little bit more sophisticated than this one, but that's essentially the idea. And the pure goal here, again, is just to get a diagnosis. If the patient's diagnosis is confirmed to be lymphoma, they'll go on to chemotherapy, which is their definitive treatment. The problem is that even though a needle biopsy is less invasive than a big open surgery, it's still a surgery. So patients need to be admitted to hospital. We need to get unscheduled operating time. The mortality rates of these biopsies have been quoted as high as 3%, given the fact that these tumors can sometimes have dramatic hemorrhages. So it's by no means a completely benign or resource-free tool, and it's not of therapeutic benefit. Patients are undergoing this risk for no therapeutic benefit. The other problem, of course, is that we have a number of patients where we don't really know which pathway to put them down. So if they have a lymphoma and go down the wrong pathway, they get overtreated and face higher risks than they should be. On the other hand, if they have one of these tumors that we should be resecting, they will go for a biopsy, and if we got it wrong, they go back for another surgery. So it's not a good use of resources. So in order to combat this, we've done some previous work looking at liquid biopsy in brain cancer in general. So this is a paper that our group published in Nature Medicine a few years ago looking at the plasma cell-free DNA methylome. And you can see that we built a sort of a pan brain tumor classifier to kind of combat these similar problems. So I'll point your attention to the first two on the left. The one on the far left is a hemangiopericytoma, which is essentially a sarcoma that grows in the blood vessels of the surrounding areas of the brain. And then the one adjacent to it is a meningioma, which is a more benign type of tumor. And you can see on the MRI they're virtually indistinguishable. But the problem is that a hemangiopericytoma is an extremely vascular tumor that can lose tons of blood in surgery. So it really matters when we go into the operating room which of these two it is. So this was an early proof of concept, and you can see that by using the methylation profile of the blood, we had reasonably high certainty looking at these probability outcomes to distinguish one from the other, which allows our planning to change. More recently, we've taken this work into the cerebrospinal fluid because we know that's a more proximal biofluid to the brain, because tumors that grow within the brain itself, like the ones I presented earlier, tend to have a lower signature in the blood. CSF has been better. So we've shown and recently published that the DNA cell-free methylome is able to distinguish these three tumor types with quite good accuracy. And then a sort of parallel project was to show that looking at the protein in the CSF of these tumors also works quite well. But the ongoing barrier to clinical implementation of all of these models, of course, is accuracy. So to convince a tumor board that this is indeed the right output, we need to kind of continue to push the envelope. And the cutting edge here is to layer these different omics technologies together to generate these multi-omic classifiers to see if we can improve accuracy. So our sort of brief hypothesis is that by integrating the methylome and proteome of the CSF in patients with new diagnosis of brain cancer, we can improve the accuracy of existing models and thereby reduce the barrier to implementing clinically. So I'm going to kind of briefly go over our machine learning pipeline. In order to integrate multiple omics data, there's a bunch of different ways of doing it. We use kind of 3 different multi-omic classifiers. So in model 1, we take methylation data, protein data, combine them into a regularized regression model called an elastic net, basically treating them as the same type of data. In model 2, they're combined in the same way, but the tuning parameters in the model are specific to the data type, so it's sort of an extra training feature. And then in model 3, we build a 2-layer classifier. So we build individual classifiers as we've done in the past, and then we combine them together in a second layer. And then our training and testing is relatively standard for this type of pipeline. So we divide the training into training and test sets at random. The training set is used to find discriminatory features. Those features are used to train a model, and that model is tested on the independent test set. And then to increase our reliability, robustness, we iterate over this 100 times, and then we generate summary statistics in order to determine how well our model worked. So I'll go through the results. So these are ROC curves of, again, these are 100 models from each of the 3 integrated models. You see that the majority of the models, about 70 to 80 of the 100 models, have an AUC of 1. And we surprisingly had an accuracy of 100% with median AUC of 1 and 95% confidence of that median of 1 to 1. And you can see, looking at the comparison of the performance between our single platform classifiers and these integrated classifiers, show that doesn't matter how you combine these data types, you get significant improvement over our previous single platform classifiers, which was surprising. And interestingly, if you look at the glioma classifier and a brain metastasis classifier, that same degree of improvement is not borne out. So there's an element of the synergism of the biology specific to lymphoma, which is sort of a fortunate outcome, because again, that's the one that is of real translational relevance. Those numbers were, of course, based on a probabilistic output. For its clinical relevance, we have to develop it into a diagnostic tool that spits out whether or not this patient has lymphoma. And so we had to derive a cutoff. So we sort of optimized it on all of our models, and then in order to increase the rigor further, we took a consensus so that if a patient was not classified as the same thing across all 3 models, we said that they were not classified. In our optimized cutoff of 0.3, this is our confusion matrix, and this is our sort of final performance as a standalone diagnostic test. So the important feature here really is specificity. If our model says it's lymphoma, we want it to be lymphoma, because we're going to say they don't need to go on for surgery. So fortunately, we ended up with a specificity of 100% and accuracy of 96%, classifying 86% of patients. We wanted to look at the biology that's being brought by these models. So first, we wanted to look at the differentially methylated probes that were hypermethylated in most of our models of lymphoma versus the others. And we saw that most of these DNA methylation probes mapped onto genes that were related to the MAP kinase pathway. And that's a fairly canonical pathway in glioma. And so we suspect probably the fact that these are relatively hypomethylated in glioma is why this is being pulled out in the lymphoma model. And interestingly, if you look at the proteins, it maps to a totally orthogonal biology. It maps to immune-related functions, particularly the adaptive immune system. And so our hypothesis, though it's speculative, is that the reason that the lymphoma models them specifically do a lot better when you combine these omics technologies is that the biology being pulled out is completely separate. So to conclude, I would sort of propose a new paradigm to how we approach new patients with undifferentiated intraaxial brain tumors. So rather than taking a guess and deciding on the pipeline and admitting them for surgery, we see them in the clinic and we do a lumbar puncture. And we wait about a week or so for that result to come back. If the result is either a tumor that we think we should take out completely, or it doesn't know, then the existing pipeline continues to exist and we make a decision. We either put them through surgery or we go through biopsy, which again is equivalently surgery. But there will be a subset of patients that, through this classifier, are determined that they are lymphoma. And again, given our specificity of 100%, we can say that with quite high confidence. And I would argue that these patients probably do not derive any benefit from surgery. And if there's a sufficiently high pretest probability, should go on directly to definitive treatment and avoid delays, healthcare costs, et cetera. So as in all these projects, there's a huge team that was involved. So thanks to Dr. Zadeh, Dr. Nasiri, my supervisors, and the whole lab who've contributed quite a lot to this. Happy to take any questions.
Good morning. That's a great presentation, Alex. Outstanding work. Just a few questions for the clinical implications and so on. What are the particular subset of patients that will benefit most from the treatment or from the diagnosis tool? Are they bad candidates also that you could say, this wouldn't be used on this? And the other one, what are the next steps, for future steps for clinical application, implementation? For example, you know, in our tumor boards, we use methylation as a predictor for patients that are going to recur tumors and so on.
Yeah, very good question. I mean, I think to your point, from a fiscal standpoint, it's not feasible to apply this to every patient, and also from a clinical standpoint. So, you know, for example, we have lots of patients who have very large brain tumors and need surgery on a relatively urgent basis. They need to be admitted to hospital. And so certainly having them undergo a lumbar puncture and wait for days and days for this and delay surgery is not worthwhile. Similarly, there's a large proportion of patients that come in that are not truly undifferentiated. A large majority of our patients, we know with a high degree of certainty that it is a glioblastoma or it's a brain met, for example, if they have tumors elsewhere in the body. In those situations, the patient doesn't really benefit from this sort of preoperative workup. The ideal candidate in my mind is someone with a relatively high pretest probability of lymphoma or truly undifferentiated, because the ones that will ultimately benefit from this are the ones who will be borne out as being diagnosed with lymphoma, obviously. Obviously, anyone that has a high surgical risk as well. If we can avoid surgery in these patients that will not need surgery for treatment purposes, that's ideal. So someone who can be managed as an outpatient, who has a reasonably high pretest probability of lymphoma, and poor surgical candidates. You mentioned how we what the next step is. I think, in my opinion, this is sort of a decision support tool going forward. As you mentioned, in our tumor boards now, we use methylation for other tumors like meningioma. We've developed outcome predictors. And our colleagues in radiation oncology and medical oncology often rely on these outputs to determine how aggressive we're going to treat patients. As you know, there's lots of patients that we think quite likely have CNS lymphoma, but it's often a difficult argument to make if we don't have any biopsy, and so we're often pushed to biopsy these relatively poor surgical candidates who we know will ultimately go on to have lymphoma and chemotherapy. But I think this is another tool in our armamentarium to say, well, maybe we shouldn't be putting all these patients under a general anesthetic. We should be going down that pipeline. And as we continue to build prospective data and more people are seeing this in a multidisciplinary fashion, then I think then it becomes a more routine type of tool that we could use.
Great. Thank you very much.
One more question, Casper.
Casper Wong from Sick Kids. I am not a neurosurgeon, but I certainly see, and we certainly see lymphoma in other parts of the body. So I have a two-part question. First of all, as you had alluded to, there are some patients that you would not want to do a lumbar puncture on. Have you done any parallel analysis looking at blood for the methylomics and the genetics of it? Does it cross the blood-brain barrier sufficiently for you to do a similar analysis in a non-invasive fashion? And number two, can this be extrapolated to other sites of lymphoma, the need to diagnose lymphoma or otherwise in the body? Great talk, thank you.
Thank you. Very good question. I think, ultimately it's ideal to have all of this done in plasma, particularly because that allows for more longitudinal monitoring of recurrence risk and so forth. Patients are more willing to be, or more likely to be willing to undergo routine blood tests than LPs. But yes, the signal does exist. It does cross the blood-brain barrier. The issue was really there's kind of a ceiling of accuracy where we just, in CSF, we're just seeing that we can get significantly higher accuracy for these tumors as it stands. But I think as we develop more sensitive tests and better classifier tools, that ultimately, hopefully, we will bring this back into plasma. But the kind of transition from blood to plasma in the intraaxial space was because of a limitation of accuracy. Your second question, I think definitely. I think probably the reason the lymphoma classifier works so well, at least in part, is that there's a robust signature in the blood, in the CSF in the patients that have brain disease. So I think very likely in those that have hematogenous disease or lymph node disease, to do the same thing in plasma would be very, very doable. Would be the next step in that world.
Thank you very much, Alex.
Thank you.
Okay, and now we move on to our last presentation for the morning. It's Dr. Kevin Ahn, and Dr. Ahn is currently a PGY5 in cardiac surgery. He completed during his residency a clinical research fellowship at Cornell and a master's in public health in biostatistics in Harvard. And his clinical research interests include cardiothoracic transplantation, mechanical circulatory support, multiple arterial grafting, transcatheter aortic valve replacement. The title for his talk is Long-Term Outcomes of Percutaneous Coronary Interventions versus Coronary Artery Bypass Grafting in Women with Severe Coronary Artery Disease. Dr. Ahn.
Good afternoon, guests, colleagues, and faculty members. On behalf of my co-authors, I'd like to thank the department for allowing me to present our work to you today. So these are my disclosures. This work was supported by the CCS Bayer Cardiovascular Research Award, and this work was also completed in partial support of my MPH degree. There are no other disclosures. So the optimal modality for revascularization of severe coronary disease remains controversial. Several large randomized clinical trials of PCI versus CABG have demonstrated a reduced MI and repeat revascularization with cabbage. However, evidence regarding mortality benefit is less clear. Additionally, the benefit of cabbage in women has been questioned as well. And this is due to a higher unadjusted in-hospital mortality and morbidity in women undergoing cabbage compared to men. We think this is likely due to differences between coronary disease and biology between women and men. We know that women tend to develop coronary disease later in life. They also have more comorbidities when they present for revascularization. Women have smaller and more vasoreactive coronaries, and they also have a smaller body habitus, which affects surgery and results in greater hemodilution. This has been associated with greater operative mortality. As a result, in clinical practice, women are less likely to be referred to and accepted for bypass surgery and more likely to be referred for PCI. Interestingly, in a subgroup analysis from the Excel trial, there actually appeared to be a significant mortality benefit at 3 years in favor of cabbage in women. This difference wasn't seen in men. However, there's a couple of issues with this analysis. One, the number of patients in this analysis was only 441. And additionally, other subgroup analysis of randomized trials did not necessarily reach the same conclusions. This led us to ask the question, does cabbage improve long-term outcomes compared to PCI in women? To answer this question, we used linked administrative healthcare databases in Ontario to generate a cohort of women with severe coronary disease who underwent PCI and cabbage. We defined severe coronary disease using the Class 1 indications for cabbage from the 2011 ACC/AHA guidelines, which includes left main disease, 3-vessel disease, and 2-vessel disease with proximal LAD involvement. We excluded patients who had a STEMI, cardiogenic shock, recent PCI within the last 6 months, previous cabbage, and patients who underwent concomitant procedures during surgery or those who had dementia. We chose to include patients from 2012 to 2021 in order to capture the more modern usage of second-generation drug-eluting stents. And we also limited our primary analysis to women under the ages of 80 and to elective patients only. This is to ensure a more comparable cohort of PCI and cabbage patients, as we know that very sick patients are more likely to undergo PCI, and patients with less coronary complexity are also more likely to undergo PCI. Our primary outcome was long-term major adverse cardiovascular and cerebrovascular events. And our secondary outcomes were the individual components of MACE, which include death, MI, stroke, and repeat revascularization. We also included a composite readmission outcome for MI, heart failure, or stroke. After our initial cohort creation, we used one-to-one propensity score matching on 33 different baseline characteristics. We matched on the number and location of diseased vessels as well. At the end of matching, all baseline characteristics maintained a standardized mean difference of less than 0.1, which indicates successful matching. We also used Cox proportional hazard model and defined grade subdistribution hazard models for non-fatal outcomes in order to account for death as a competing risk. Robust variance estimators were used to account for clustering within matched sets. And this is our flow diagram. From an initial cohort of 24,965 patients, after our initial exclusions, we had 15,344 patients. For our primary analysis, we excluded the non-elective patients and patients over 80 years of age, after which we were left with a cohort of 6,190 patients. After propensity score matching, there were 2,033 patients in each cohort, in each group. PCI and cabbage patients differed before matching, which is what we expected. At baseline, the average age was 66.5, and particularly interesting was that left main disease was more common in cabbage. These are our initial in-hospital outcomes. After matching, in-hospital death and stroke were higher with CABG, while in-hospital MI was similar between the two groups. For the primary outcome of MACE, at a median follow-up of 5.1 years, MACE was higher with PCI. The hazard ratio was 1.79. For all-cause mortality, at a median follow-up of 5.1 years, mortality was higher with PCI. The hazard ratio was 1.33. Long-term MI was higher with PCI with a hazard ratio of 2.28. Repeat revascularization was higher with PCI with a hazard ratio of 2.84. Stroke was lower with PCI with a hazard ratio of 0.85. The composite readmission outcome of MI, heart failure, or stroke was higher with PCI. The hazard ratio here was 1.42. To test the robustness of our findings, we also conducted a number of sensitivity analyses. First, we included in our cohort women who underwent inpatient or urgent revascularization. We then included women over the age of 80 as well in our cohort. And we also excluded patients who had a previous cardiac surgery consultation prior to PCI. All these sensitivity analyses reached similar conclusions to our primary analysis. Finally, we used a falsification endpoint of pneumonia, which showed the incidence of pneumonia, an unrelated outcome, was similar between PCI and CABG. There are a number of limitations to our study. As you know, it's an observational study which, despite propensity score matching, results in that we cannot adjust for unknown confounders, and this may impact our findings. Additionally, due to the nature of administrative health databases, we do not have complete data granularity around stents, type, and graft placement. Finally, the definition of MI we used in this study was a clinical definition. We did not have biochemical markers in our database. So in summary, in our study, we found that women with severe coronary disease may derive greater long-term benefit with CABG compared to PCI. Our results were consistent with data from a New York State database by Hannon et al., which compared CABG and PCI in women from 2012 to 2018, which showed a 6-year mortality and MACE was higher in PCI compared to CABG with a hazard ratio of 1.29 and 1.28. Important to note, the greater long-term benefit of CABG occurred despite a higher in-hospital mortality. What are the implications of this? Well, there are several. A study from the National Inpatient Sample in the US showed that women with multivessel coronary disease are half as likely to undergo CABG compared to men. This is due to a number of factors, including comorbidities, operative risk, and other patient-related factors. However, our results show that despite this higher operative risk, women continue to derive greater long-term benefit from CABG in a real-world population. And our results suggest that in an appropriately selected women, the treatment recommendation should shift towards CABG. Thank you very much for your attention, and happy to answer any questions.
Thank you very much, Kevin. The discussant for this paper is Dr. Whitesell.
Thank you very much, and Kevin, congratulations on an excellent presentation and a great study. This is an important study because we really need to know why women don't do as well with coronary disease, but more important, what do we do about it? We have to do a tailored therapy for these groups, and we have to know what the problem is in order to cure it. So this is an excellent study, and the other thing about your study is it's a real-world cross-sectional evaluation of all the patients in Ontario. What an amazing opportunity. And that's only in Ontario. You can't get that in the United States. In addition, the ICES data has got all interventions with the medical profession, right? So the long-term data is complete. Wow, what a great opportunity. So congratulations on that. I have 2 questions for you, and I'll ask them one at a time. So the first relates to your concern about why CABG is better than PCI, and that's because it's diffuse disease in the women, And when you do PCI, you only do the proximal lesion. That's it. That's all they can do. And do CABG, you go distal to the diseased vessel, and you do a bypass around it. So it doesn't matter whether you've got a disease now or in the future, you're going to bypass it. It's already bypassed. So that's why CABG may be better. But the other question is, why do women have more diffuse disease? As you say, they are different. They're smaller, more vasoreactive vessels, but that's not the only reason. It's later. They are not diagnosed properly. They are not treated adequately. And that's a major concern in our whole society. And that's something we can treat. So maybe we should adopt the American and Canadian Heart Association's Go Red for Women. We have to get people to understand that women's symptoms of coronary disease are much less than men, and they're very unusual. They're minor. Get people to understand that even minor symptoms have to be investigated so that women can be treated at the same time as men, so we can finally get the same results instead of worse results. So that'd be the first thing. Would you agree that that's an approach that we should take?
Well, Dr. Weiss, I don't know if I could even disagree on the podium here. But truthfully, absolutely, you're completely right. I mean, if we look at some of this, if we look at our data, we had 15,000 patients in our cohort. After we excluded patients who had an urgent or inpatient revascularization, we only had around 6,000 to 7,000 patients left. So that shows you that over half of women are being revascularized as an inpatient. So they're presenting with symptoms. They're only presenting when it's almost too late, when their outcomes are going to be worse. We know that this is not the case in men. Men present with more typical symptoms. They're much more likely to be diagnosed and treated as electively as an outpatient. I think part of this is also due to, as you alluded to, public awareness. I think, growing up, everyone is aware that men in their 50s, 60s, 70s are at high risk for heart disease. But that is not the case for women. And a lot of women are under-recognizing their own symptoms. A lot of physicians are under-recognizing women's symptoms when they present to medical care. And this is resulting in a situation where women are presenting late, they're presenting urgently, and their unadjusted short-term outcomes are higher, are worse compared to men.
So the second question I have for you relates to the early mortality. Unfortunately, 1.5 for surgery and 0.7 for PCI. So why is that? Why do women don't do as well with surgery as men? Now, you suggested that it's related to hemodilution. And in a previous paper that you wrote, together with Dr. Guadino's group and published in JACC this year, you found that 39% of the increased mortality was related to hemodilution. In other words, preoperative anemia of these women patients. And then in another paper that they published last year, it indicated that that was related to transfusion. So how do we avoid transfusion and hemodilution in women? Well, there are a number of ways to get about that. They just are not very popular. So I think another alternative we have is to have tailored therapy for women who undergo surgery. So it can reduce that mortality by avoiding hemodilution and avoiding transfusion. You think that'll work?
Absolutely. I think when we look at this, there's obviously a lot of solutions to try to reduce the amount of transfusion during surgery. And we know that, as you mentioned, women have a smaller body habitus, they have less blood volume, they have a lower baseline hematocrit, and when in surgery, their intraoperative nadir hematocrit drops below 22%, this really increases their operative mortality. There's options including preoperative IV iron, there's options including retrograde autologous priming, but all these options, as you alluded to, have their own downsides and consequences and are not quite popular in clinical practice. So I do believe that we do need better solutions to try to reduce this an early operative mortality. This will particularly help women because of their sort of higher risk for intraoperative humiliation compared to men.
Thank you.
Thank you very much. Thank you, Kevin, and to all presenters for this fantastic morning, and I pass it along to Dr. Feelings.
Thank you, Moji, and congratulations to the speakers and their supervisors for a fantastic start to the morning. So we are going to break for an hour. Grab a coffee and a refreshment, and please visit the e-posters. The directions are outside, and we will reconvene in an hour at 10:45.